Hello everyone. Through this video, we can gain some knowledge about multiple pregnancy. We'll go into the subject. I'm Ruth Kesia working as a tutor in Triple M College of Nursing. The objectives of this video, we are going to learn about incidence, diagnosis of multiple pregnancy, mechanism of twinning, complications, causes of the perinatal mortality and the morbidity, twin to twin transfusion syndrome, antenatal management of the multiple pregnancy, assessment of the chorionicity by ultrasound and management of the labor in multiple pregnancy. Incidence. The natural rate of twinning is 1 into 90. It means out of 90 the pregnancies, one pregnancy can be of a twin pregnancy, slightly higher in blacks than whites. In USA, the incidence is 3%. The incidence is increasing due to the assisted reproductive technique and ovulation reduction. The incidence of monozygotic twins is constant and is 4 is to 1000 pregnancies. The incidence of dizygotic twins increases with age, parity, weight, height, and is higher in some families. So we'll see about the monozygotic and the dizygotic in this zygosity. Okay, so just you have to know the monozygotic incidence is 4 is to 1000, and the dizygotic increases with age, parity, weight, height, and higher in some families. The factors that influences twinning are the causes of twin pregnancy is not known. Okay, so but there are some risk factors, namely race, highest among the Nigerians once in every 20 births, lowest among the Mongols and intermediate among Caucasians. Hereditary, family history in mother, maternal age and parity, twinning peaks at 37 years and increasing parity, fifth gravid onwards. Nutritional factors, taller, heavier women, twinning rate 25 to 30% greater. Pituitary gonadotrophin, infertility therapy, assisted reproductive technology, all this can cause twinning or multiple pregnancy. So we'll come to the zygosity here. First is dizygotic. Dizygotic means there will be two amnions and two chorions will be there. 70 to 80% of all twins, fertilization of two ova, and each fetus will be surrounded by amnion and chorion. Each fetus has its own placenta. So if it comes to dizygotic, as the name implies, there is two zygote. It means there is two ovum. Okay, these two ovum will be fertilized by two sperms. So there is two ovums and two sperms, and each ovum and each sperm will give birth to a fetus, and these fetus will have the covering membranes will be separate for these two fetus. Okay, in case of dizygotic, each fetus will have one amnion and one chorion covering. It means each fetus will have two coverings on surrounding them. Okay, also each fetus will have separate placenta. Okay, so this is very important in case of a dizygotic. There will be two separate membranes covering the fetus and there is two different placenta. And in case of monozygotic twins, 20 to 30% of all twins accounts for this monozygotic twins result from cleavage of a single fertilized ova. The timing of cleavage determines the placentation. Okay, so in the previously dizygotic, I told you the cleavage there will be two sperms and two ovums, but in monozygotic, okay, as the name implies, there is only one zygote. It means there is only one egg. Okay, so this one egg is fertilized by one sperm only, so it has to give birth to, I mean, give rise to one fetus, but there will be cleavage occurring. So this cleavage can occur at any days of during the first trimester. It can be between 0 to 4 days, 4 to 8 days, or 8 to 12 days. So okay, so it depends upon the day of cleavage. Okay, timing of the cleavage, there will be placentation. So it determines whether there is a single placenta or both placenta, the double placenta, or if whether the connected placenta. Okay, so all this will be determined by the timing of the cleavage. Okay, so that is called the monozygotic twins. So in dichorionic and diamniotic monozygotic twins are there. Okay, so it means even if the sperm and egg is fertilized, there is only one sperm and one egg, and they are the cleavage is formed and the twins are formed. Okay, the this fetus can have two coverings around them. Okay, each fetus can have amnion and chorion, separate amnion and chorion. But this can occur only if the cleavage occurs in the first 3 days. But if the cleavage occurs after 4 days and all, there this chorion and amnion will not be separate for this each placenta, as you see in the picture. Okay, so in the first picture it shows one egg and one sperm, but it gives rise to twins, right? So in this first picture there is same placenta and the same amniotic sacs are there. But in the second picture, as you see, there is two eggs and two sperms. Here they are having separate placentas and they are having separate coverings around them. Okay, they are called the fetal membranes, otherwise called the amnion and the chorions. Okay, and this is about the monozygotic twins. Each fetus is surrounded by amnion and chorion. Each fetus has its own placenta like dizygotic twins, has the lowest mortality rate. If the monozygotic twins are having diamnion and dichorion, it means each fetus is having their own separate amnion and chorion. The mortality rate is low. Okay, but if the amnion and chorion is shared by these placentas, okay, if they are having a common amnion and a chorion and a common placenta, the mortality rate is high. Monochorionic diamniotic. So as the name implies, here there will be single chorion. So the chorion is the outermost layer and the amnion is the inner layer. Okay, so the inner layer will be separate for two twins, but the outer layer is common. Okay, so this happens when the cleavage occurs at the 4 to 8 days after fertilization. Share single placenta but separate amniotic sac. The mortality rate is 25%. Whereas in monochorionic and monoamniotic, so these are the two layers which are surrounded by the fetus. Okay, both two fetus are there, but they are having a single amnion and a single chorion. Okay, so this occurs less than 1% of the cases. Okay, where the cleavage occurs after 8th day, 9 to 12 days. They will have a single placenta and single sac. The mortality rate is 50 to 60%, usually before 32 weeks. So as you see in the picture, the picture explains clearly. The first picture has two amnion, two chorion and two separate placenta. In the second picture, there is two amnion, one chorion and the placenta is fused at the margins. Okay. And the third picture, there is two amnion, one chorion and there is single placenta. In the fourth picture, there is one amnion and one chorion and one placenta. So as you see, the mortality rate great increases, right? So 13 to 44% the mortality rate is increased here as it's shown in the picture. Okay. On rare occasion, the following possibilities may occur. If the division takes place within 72 hours after fertilization, the resulting embryos will have two separate placenta, chorions and amnions. 4 to 8 days, there will be diamnion, monochorion, and after 8th day, there will be monoamniotic, monochorionic twins will be developed. So as we saw already, this is about the examination of placenta and the membranes. In case of a dizygotic twins, so it means there is two ovum and there is two separate sperms are there. And two placenta will be there, either completely separated or more commonly fused at the margin, appearing to be one, but it is not fused, it will be appearing to be one, and there is no anastomosis between two fetal blood vessels. And in case of monozygotic twins, the placenta will be single. Varying degrees of anastomosis between two fetal blood vessels will be seen. Each fetus is surrounded by amnion and chorion. Each fetus is surrounded by a separate amniotic sac with single chorionic layer common to both. Intervening membranes consist of four layers: amnion, chorion, chorion, and amnion. In case of monozygotic twins, the intervening membranes consist of two layers of amnion only. So this is about the anastomosis between the placenta. As you see in the picture, there is two twins, but they are sharing a single placenta. So while the twin, to determine about the sex, okay, about what will be the sex of this uniovular or biovular, monozygotic or dizygotic, what will be the sex? So while twins having opposite sex are always biovular, and twins having of the same sex are not always uniovular, but the uniovular twins are always of the same sex. So nothing to worry here. Okay, so if there is only one ovum, okay, and the cleavage is occurring and they give rise to twins, means there will the sex of the two babies will be same. It is always the same sex. When there is single ovum, single sperm, and the cleavage is occurring and that gives to monozygotic twins, means in that case the sex of the twins will be or definitely same. But if there is two worms are there and they are fertilized by two different placent, two different sperms, okay, so then the sex of the baby may be same or may be different. Okay, that's what given here. If the fetus are of the same sex having same genetic features and monozygosity is likely. A test skin graft, acceptance of the reciprocal skin graft, proof of monozygosity. DNA microprobe technique is more definitive. Follow-up study between 2 to 4 years showing almost similar physical and behavioral features suggestive of monozygosity. So Siamese twins. What is Siamese twins? On rare extreme occasions, divisions occur after 2 weeks of the development of the embryonic disc, resulting in the formation of the conjoined twins called Siamese twins. So these conjoined twins may be of four types. Okay, the fusion may occur maybe of four types: thoracophagus, pyophagus, craniophagus, and ischiophagus. Okay, as you can see in the picture, thoracophagus is the commonest, pyophagus is posterior fusion, and the craniophagus is the cephalic fusion, and ischiophagus is the caudal fusion. So this is an example of the thoracophagus twins. So here the cleavage occurring after 2 weeks. So that then only give this kind of fusion will be occurring. Okay, this is an example of thoracophagus conjoined twins. The cleavage occur after 12 days. Incidence is 1 is to 70,000 deliveries. The fetus may fuse in a number of ways, most commonly chest and or abdomen. So this is about the mechanism of twinning. So in case of a 0 to 4 days, if there is cleavage, okay, so we are not bringing where there is dizygotic diamniotic, okay. It means two ovum will be there and two sperms are there. So in that case, the baby will be formed, two babies will be normally formed. But when there is a single ovum and single sperm, so this mechanism of twinning will occur at any days. Okay, this in case of it, if it occurs between 0 to 4 days, the fetus fetus will have the dichorions and diamnion. It means each fetus has its own outer membranes. If the cleavage occurs between 4 to 8 days, there will be monochorion and diamniotic. If the cleavage occurs between 8 to 12 days, there will be monochorion and monoamniotic layers. So this is what you should know about the layers of the fetal membranes and the timing of the cleavage occurring. Okay, that's called the mechanism of twinning. So the same process explained in this picture also. We'll come to the complications of multiple pregnancy now. High perinatal mortality, morbidity will be there, 3 to 4 times higher than singleton pregnancy, and abortion will be there, greater less than 50% of twin diagnosed in the first trimester result in live birth vanishing twins, and nausea and vomiting will be there. It will be exaggerated of nausea and vomiting. Preterm labor will be there, IUGR, and PET 3 times higher than singleton, and polyhydramnios, congenital anomalies, postpartum hemorrhage, placental abruption, placenta previa, discordant twin growth, and malpresentation, cord prolapse, operative delivery. These are some of the complications of multiple pregnancy. Causes of perinatal mortality and morbidity. It means what are the causes of these complications. Okay, how this complication arises mainly because of prematurity, that is the respiratory distress syndrome, birth trauma, and cerebral hemorrhage, birth asphyxia, congenital anomalies, and stillbirth. Perinatal mortality means morbidity means how what are the reasons the fetus will die or the newborn will die because of this multiple pregnancy is that prematurity, birth trauma, and cerebral hemorrhage, birth asphyxia, congenital anomalies, and stillbirth. So this is called twin to twin transfusion syndrome. This is a term you should know in case of a multiple pregnancy. So it occurs in 2 to 20 to 25% of monochorionic twins. So and one fetus donate blood to the other due to vascular anastomosis. So I told you there will be a single placenta and varying degrees of fetal anastomosis between the fetal blood vessels. Because of this anastomosis, okay, there will be donation or there will be receiving of the blood vessels from the between the fetus. So this should not happen, but because of this fetal anastomotic blood vessels, because there is single placenta and there is varying degrees of anastomosis between these two placentas, there will be donation of the blood between the fetus. The recipient fetus will have heart failure, polyhydramnios, hydrops. The donor will have IUGR and oligohydramnios. So management includes amnioreduction of the twin recipient twin, intrauterine blood transfusion for donor twin, selective fetal reduction, and fetoscopic laser ablation of the placental anastomosis. So this selective fetal reduction will be done when there is more than 2 or 3 in case of triplets, quadruplets. Okay, in that case they will go for selective fetal reduction, that too only in the first trimester. And then there will be the degrees of anastomosis will be identified, and the fetal fetoscopic laser ablation, it means they will cauterize these anastomotic blood vessels. Dead fetus syndrome. So this is another term like twin to twin transfusion. This is another term, dead fetus syndrome. Death of one twin will occur. It is associated with the poor outcome of the co-twin, specifically in monochorionic placenta. Okay. Surviving twin runs the risk of cerebral palsy, microcephaly, renal cortical necrosis, and DIC. So if the one of the twin is dead, the other twin which is surviving, okay, that twin is also will also have so much of complications like cerebral palsy, microcephaly, renal cortical necrosis, and DIC. This is because the thromboplastin liberated from the dead twin that crosses via placental anastomosis to the living twin. Because of this, the living twin is also affected. Then the other term is the twin reversal arterial perfusion. So it is characterized by a cardiac perfused twin having blood supply from a normal core twin via large arterial anastomosis. Okay, so what it says here, a cardiac twin. The one twin will be normal, but the other twin will be acardiac. It means without any heart. There will not be any heart, there will not be any head. Okay, it is amorphic. Amorphic means the fetus is not completely formed. Okay, fetus is only formed. Okay, there is no heart, there is no lungs for this a cardiac twin, but this still this twin will have blood supply from the normal twin. Okay, so that is because of a large arterial anastomosis, that's called trap, twin reversal arterial perfusion. Conjoint twin, which is rare, and perinatal survival depends upon the type of joint. Major cardiovascular anastomosis leads to high mortality. So this is an example for a fetus acardiac twins, where the one of the twin is completely formed while the other doesn't have any head or heart or the liver. Okay, it is amorphic. It is not completely formed. That's called twin reversal arterial perfusion. Fetus, which occurs in case of a fetus acardias. So there's a research evidence. Okay, there's a woman who's a 26-year-old G2P1, which initially seen in 16th week of twin gestation, and a cardiac acranial twin was present. There were spontaneous movements of the lower extremities. Chromosomal analysis of the amniotic fluid shows two normal females. Several ultrasonographic examinations showed lack of growth of the malformed twin but appropriate growth of the normal twin. Spontaneous labor developed at 40 weeks, and a normal female weighing around 3.2 kg with Apgar score of 9 by 10 was delivered, and the acardiac twin was approximately 10 centimeter long and was spontaneously delivered out of a second amniotic cavity. The pathologic findings of this acardiac twin shows which it was 31 grams in weight, 10 centimeter long, showed no heart, no or lung development. Liver, intestine and urogenital tract appear normal. Spleen, pancreas and stomach were absent. The placenta was monochorionic, diamniotic, and the two umbilical cords were interconnected by a direct anastomosis. So this was the research evidence for a twin acardiac syndrome. So there are some of the terms you should know in case of a multiple pregnancy. The terms are, first is superfecundation. Okay. So what is superfecundation? Superfecundation is the fertilization of two different ova released in the same cycle by separate act of coitus within a short period of time. Next is superfetation. It is the fertilization of two ova released in a different menstrual cycle. The nidation and the development of one fetus over the another fetus is theoretically possible until the decidual space is obliterated by 12 weeks of pregnancy. Next is fetus preparations or compresses, is a state which occurs if one of the fetus dies early. The dead fetus is flattened and compressed between the membranes of the living fetus and the uterine wall. It may occur in both varieties but is more common in uniovular twins and is discovered at delivery or earlier by sonography. Next is fetus acardias. Occurs only in uniovular twins. Part of the fetus remains amorphous and becomes parasitic without a heart. Next is vanishing twin. Occasional death of one twin and continuation of pregnancy with the surviving one. The dead fetus, if within 14 weeks, simply vanishes by resorption. So these are the some of the term should be learned in multiple pregnancy can come across. So next we'll come to the diagnosis of multiple pregnancy. So in case of history and physical examination, what all we are going to look. Okay, in case of history, you have to look for recent administration of either clomiphene citrate or gonadotropins or pregnancy or whether the pregnancy is accomplished by ART or much stronger associates. Okay, and clinical examination with accurate measurement of the fundal height. In women with a uterus that appears large for gestational age, the following possibilities are considered: multiple fetus, elevation of the uterus by distended bladder, inaccurate menstrual history, hydramnios, identiform mole, uterine leiomyomas, a closely attached adnexal mass, fetal macrosomia. All this can be considered in case if the uterus appears large for the gestational age. Symptoms. There will be minor symptoms of normal, the minor symptoms which are normally exaggerated, like increased nausea and vomiting in the early months, cardiorespiratory embarrassment, tendency of swelling in the legs, varicose veins and hemorrhoids is greater, unusual rate of uterine enlargement, excessive fetal movements. General examination, prevalence of anemia is more, unusual weight gain, not explained by preeclampsia or obesity. Evidence of preeclampsia is a common association. In case of abdominal examination, in inspection we can note a barrel shaped and abdomen is unduly enlarged. In palpation, the height of the uterus is greater than the period of amenorrhea. Girth of the abdomen is greater than the normal average girth at term. So normally it should be 100 centimeter at term, but in case of multiple pregnancy it will be more at term, more than 100 centimeter. Fetal bulk disproportionately large in relation to the size of the fetal head, and palpation of too many fetal parts would be there. Finding of two fetal heads or three fetal poles can be felt in the palpation. In auscultation, two distinct fetal heart sound at separate spots can be heard. Difference in the heart rate is at least 10 beats per minute. Okay. Investigation in ultrasonography, there will be separate gestational sacs, and it is confirmed as early as 10th week of pregnancy. Variability of fetuses, vanishing twin in second trimester, chorionicity, that is twin peak sign, can be identified, and pregnancy dating fetal anomalies can be ruled out. Fetal growth monitoring, presentation lie of the fetus can be ruled. Twin transfusion, localization, amniotic fluid volume, all this can be detected in the ultrasonography. Biochemical test shows levels of HCG in plasma and in urine are higher. Maternal serum alpha fetoprotein level is elevated. Unconjugated estriol is approximately double in multiple pregnancy. In radiologic examination, as you see in both picture, in the first picture, near to the arrow mark, there is a small triangle like structure. Okay, small black color triangle like structure you can see in the ultrasonogram. Okay, so that is called the twin peak sign or lambda sign. So that is given in the second picture also. Okay. Assessment of chorionicity. So multiple gestation sacs can be identified in the first trimester. Conjoined twins can be identified. Two separate yolk sac can be seen here. The third picture, two gestational sac, two different gestational sac can be identified. So as I told you earlier, the twin peak sign, that is a lambda sign, is seen where there is two chorions. It means in the first picture, okay, it shows there is two fetus, okay, there is twins, okay, but the twins, they are having, each of them having their own amnion and chorion, okay. Both the fetus is having one amnion and chorion. The second fetus is also having one amnion and chorion. So the intervening membranes, the intermembranes between two fetus are amnion, chorion, and chorion and amnion. So there is four membranes present between two twins in case of a dichorionic twins, which is the first given in the first picture. That's called a twin peak sign. If there is dichorionic twins, if there is two chorions, this twin peak sign can be identified in the ultrasound. If there is no, if there is monochorionic, it means only two amnion is separate for each fetus, but the outer layer chorion is only one layer, is that is common to both twins. It means it shows T sign. Okay, as you see in the picture, the T sign is seen in the monochorionic twins. So this is about the diagnosis of the multiple pregnancy, history, physical examination, the biochemical test, and the radiologic examination. Now we'll come to the antenatal management. Adequate nutrition should be given. Prevention of anemia should be done. Ultrasound should be assessed consecutively. Knuckle translucency should be assessed. And assessment of fetal growth and well-being. Multi-fetal reduction may be offered in higher order multiple gestation in the first trimester. Preterm labor risk, serial. So in case of preterm labor risk, serial cervical length should be assessed. Okay, the whether the cervix is getting effaced or not, you have to assess frequently. Okay, consecutively. In case of a preterm labor risk, steroid should be given for the fetus for fetal lung maturation. Antepartum management of the twin pregnancy. The aim is to reduce the perinatal mortality and morbidity rates in the pregnancy the complicated by twins. It is imperative that delivery is markedly preterm neonates, delivery of the markedly preterm neonates. Okay, so delivery of the neonate which who is less than 37 weeks should be prevented. Fetal growth restriction should be is identified, and afflicted fetuses be delivered before they become moribund, and fetal trauma during labor and delivery should be avoided, and expert neonatal care should be available. Okay, so the second point is fetal growth restriction be identified, and afflicted fetuses should be delivered before they become morbid. Management. Nutrition counseling should be given, fetal evaluation should be done, evaluate the woman for signs and the symptoms of obstetrical complication. PTL prevention should be done, explain for hospitalization, encourage bed rest and hydration, institute fetal monitoring and assist with the tocolytic therapy if ordered. Explain to the woman that the mode of delivery depends on the presentation of the twins, maternal and the fetal status and gestational age. Increased calorie requirements, protein, minerals, and vitamins and essential fatty acids should be met. Calories should be increased by another 300 kilocalorie per day. Supplementation with 60 to 100 milligrams per day of iron and 1 milligrams per day of folic acid should be given. Bed rest, antepartum surveillance, test of fetal well-being, prevention of preterm delivery, hospitalization, use of corticoids should be followed. Management during the labor. In case of first stage, a skilled obstetrician should be there, presence of ultrasound machine and experienced anesthetist, bed rest to prevent early rupture of membranes, limit use of analgesic drugs, careful monitoring, internal examination soon after the rupture of membranes, and intravenous line with the ringer raclette solution. Availability of 1 unit of compatible and cross-matched blood should be ready. Neonatologists should be present at the time of delivery. During the delivery of the first baby, the same guidelines as in normal delivery is followed with liberal episiotomy. Forceps delivery, if needed, should be done preferably under pudendal block anesthesia. Do not give intravenous ergometrin with the delivery of the anterior shoulder of the first baby. This will be followed only in case of a singleton pregnancy. But in multiple pregnancy, in case of a twin delivery, okay, we should not give the intravenous ergometrin with the delivery of the anterior shoulder of the first baby, because you have to still deliver another baby from the uterus. This ergometrin basically contracts the uterus. Okay, clamp the cord at two places and cut in between. At least 10 to 8 to 10 centimeter of the cord is left behind for administration of any drug or transfusion if required. The baby should be labeled 1. Conduction of labor after the delivery of the first baby. So how we should conduct the labor of the second baby is: identify the lie, presentation, size and FHS of the second baby. Vaginal examination should be done to confirm the abdominal findings and exclude cord prolapse, and if any, to note the status of the membrane. If the lie is longitudinal, low rupture of membranes can be done. Syntocin administration, internal examination to exclude cord prolapse. If the uterine contraction is poor, administer 5 units of oxytocin. Third step, if there is still delay, interference should be done. In case of a vertex presentation, low down forceps are applied. If there is high, if the head is still high up, okay, if the head is not still engaged, then CPD should be ruled out. The possibility of hydrocephalic head should also be kept in mind and excluded by ultrasonography. If these are excluded, internal version followed by breech extraction is performed under general anesthesia. Ventos is another effective alternative, and in case of breech extraction should be done. If the lie is transverse, we can correct the lie and bring it to vertex presentation, where we can bring it to longitudinal lie by external version or internal version to cephalic or podalic. Indication of urgent delivery of the second baby: if there is severe vaginal bleeding, if there is cord prolapse, an inadvertent use of IV ergometrin with the delivery of the anterior shoulder of the first baby, and first baby delivered under general anesthesia, appearance of fetal distress. In all this case, the delivery of the second baby should be conducted very urgent. Delay in the birth of second twin. The birth of second twin should be completed within 45 minutes of the first twin being born, but with the close monitoring can be extended if there are no signs of fetal compromise. The risk of delays are intrauterine hypoxia, birth asphyxia and sepsis. Third stage management, routine administration of 0.2 milligrams of methergine IV with the delivery of the anterior shoulder of the second twin and delivery of the placenta by controlled contraction. Continue oxytocin drip for at least 1 hour following the delivery of the second baby. The patient should be carefully watched for about 2 hours after the delivery. So, what are the interpartum management? The nursing management during the labor is establish IV access, provide electronic fetal monitoring for each fetus separately. Double setup is recommended for delivery. Availability of 2 units of cross-matched whole blood, IV access with a large bore catheter, and surgical suite immediately available. And obstetrician assistant experienced in vaginal births of twins, and best choice of anesthesia is epidural. Anesthesia provider capable of administering general anesthesia, neonatal team for each neonate present at birth for neonatal resuscitation. Pitocin induction augmentation may be required secondary to hypotonic labor. Postpartum hemorrhage may occur due to uterine atony. All this can we should be anticipated, and we should be ready to do management in case of complications. Indications for cesarean sections. Obstetric causes are placenta previa, severe preeclampsia, previous cesarean section, cord prolapse of the first baby, abdominal uterine contraction and contracted pelvis. For twins, both the fetus or even first fetus with a non-cephalic presentation, twins with complications like IUGR, conjoined twins, monoamniotic twins, monochorionic twins with TTS, all these are some of the indications for cesarean section. Postnatal management, care of babies. Immediate care should be given. Maintenance of body temperature, use of overhead heaters. Parents given the opportunity to check the identity tag and cuddle them. Breastfeeding, provide the knowledge to mother regarding different positions of breastfeeding along with the advantages, attachment and positioning timing. Postnatal period, in the nutrition will be expressed breast milk is best for small babies. They may need to be fed intravenously or by nasogastric tube or cup fed depending on their size and general condition. Careful monitoring of weight gain, regular capillary blood glucose estimation should be done. Reassure her that lactation responds to the demands made by the babies sucking at the breast. At feeding times, mother must be provided support and advised on positioning and fixing babies. Care of mother, slow involution of the uterus, increased after pain, so analgesic should be offered. High calorie diet should be given. Teach extra support to handle twin babies. These are some of the nursing diagnoses with the multiple pregnancies. There will be anxiety, deficient knowledge regarding high risk situation and preterm labor, risk for imbalanced nutrition less than or more than body requirements, risk for fetal injury, risk for maternal injury, risk for deficient fluid volume, risk for impaired gas exchange, risk for activity intolerance, risk for ineffective compromised family coping, risk for interrupted family processes. Some of the nursing diagnosis for cesarean section is deficient knowledge regarding surgical procedure and postoperative regimen, anxiety, powerlessness, risk for acute pain, risk for infection, risk for impaired fetal gas exchange, risk for maternal injury, and risk for decreased cardiac output. So I think you gained some of the knowledge regarding the multiple pregnancy. We saw about the incidents, the factors that are associated with the incidence of multiple pregnancy, the zygosity, or what is dizygotic and what is monozygotic. Okay, what is diamniotic, what is monoamniotic. Okay, what is dichorionic. Everything we saw in the zygosity, and we saw about the causes of the complications of the multiple pregnancy and what are the causes of perinatal mortality and morbidity, and we saw about the diagnosis, the history and the physical examination, blood test and the radiologic examination, and we saw about the some of the terms related to multiple pregnancies like TTTS and TRAP syndromes, and we also saw about the management of the multiple pregnancy during antepartum, intrapartum, and the postnatal period. So I hope you gain some knowledge regarding the multiple pregnancy. Thank you, all.